Hello and welcome to At the Forefront Live. Many women who undergo a mastectomy to treat breast cancer go on to have one or both breasts reconstructed. Dr. Rebecca Garza and Dr. Stacy Tessler Lindau join us to discuss the latest in breast reconstruction techniques and the sexual health concerns caused by cancer and its treatment. Remember, we'll take your questions during our program. That's coming up right now on At the Forefront Live. And we want to remind our viewers that today's program is not designed to take the place of a visit with your physician. Let's start off by having each of you introduce yourselves and tell us a little bit about what you do here at UChicago Medicine. And Dr. Lindau, we'll start with you.
Hi, good afternoon. I am an obstetrician gynecologist, and I see patients who present with concerns about loss of sexual function, oftentimes in the setting of cancer diagnosis and cancer treatment. I'm also a scientist and study how we can best preserve and recover sexual function in women with illness and as we age.
And Dr. Garza?
Good afternoon. Thank you for having me. My name is Rebecca Garza. I am an assistant professor of surgery within the section of plastic and reconstructive surgery, and I specialize in breast cancer reconstruction, the surgical treatment of lymphedema, and general plastic surgery and reconstructive procedures, including aesthetic surgery, head and neck, and trunk reconstruction.
And Dr. Garza, we're going to start off with you with our first question. We're going to ask, who's a good candidate for breast reconstruction?
Well, most women who have breast cancer who have to undergo either partial or total mastectomy can be considered as good candidates for breast reconstruction. In the past and probably out in the community, many people think that we only need to reconstruct the breast if the whole breast is removed. And that is true. However, we also have great techniques to help reconstruct breast even after partial mastectomy that can help improve the cosmesis of the breast, that can help with symmetry between the affected breast and the contralateral breast. So many women who end up with breast cancer treatment here at the University of Chicago, the majority are considered for reconstruction. And I think it's most important that all women with breast cancer know what their options are before they undergo any sort of surgery for their breast cancer treatment. And luckily, we have a great multidisciplinary team here where women are offered multiple options for both gynecologic management as well as the reconstruction of their breast.
And you mentioned the multidisciplinary team, which I think is very important in all aspects of what happens here at UChicago Medicine. And it's very important when you work with women throughout this difficult situation. And Dr. Lindau, I know you're involved, particularly with the aspect of sexual function after the fact. And can you tell us a little bit about that, and how does having a mastectomy affect that area?
So many, but not all women who undergo mastectomy experience some change, at least short term, and for some it's much longer term in their sexual functioning. Why? Well, the breasts for many women play an important role in sexual function. First of all, a woman, when she's recovering from treatment, may experience pain. Mobility may be more difficult because of this. And so just getting in a comfortable position for sex can be challenging. Some women experience difficulty emotionally or psychologically with the changes to their breasts, either the appearance, the scars, or just the angst and fear of a breast cancer diagnosis that can interfere with sexual function. And it's important to note that the breast, the female breast, specifically the nipple areolar complex, has an important erectile function. Many people don't recognize this, but the responsiveness of the nipple areolar complex to sexual stimulation is very important for many women to sexual arousal and orgasm. And so loss of that function or numbness in the breast can make it very difficult to derive pleasure from sexual activity.
And you mentioned just the psychological impact of a major surgery or a major procedure, that has a huge impact on a human being, and then you add in the different physical aspects, and that's got to be a big challenge. And I think it would be remiss if I got through the show and we didn't talk a little bit about PRISM, because I know, Dr. Lindau, that's a big part of what you do here at UChicago Medicine. Can you tell us a little bit about what PRISM is and what that does for people?
Absolutely, thank you. And you were asking about the interdisciplinary nature of our work. Both Dr. Garza's and our work calls on disciplines, surgery, gynecology, psychology, psychiatry, and PRISM. It's not PRISM, which could be misunderstood, but PRISM, Program in Integrative Sexual Medicine, is exactly this, an interdisciplinary approach to helping women preserve and recover their sexual function in the context of cancer and other illnesses. So we are fortunate at the University of Chicago to have a fantastic team of psycho-oncology trained doctors and psychologists who specialize in helping people with the psychological and emotional recovery from cancer. We have, of course, the gynecology surgeons and doctors, the breast surgeons and reconstructive surgeons like Dr. Garza. We oftentimes draw on sleep medicine. Interference with sleep can happen because of discomfort, pain or discomfort after surgery, and anxiety related to cancer treatment. If sleep isn't good, sexual function may not be good. If sleep isn't good, it is hard for one's immune system to fully function and recover from cancer and cancer treatment. We also work with our nutrition and diet services as well.
So, Dr. Garza, let's talk about the different types of reconstruction, because I think when people think of a cancer diagnosis, they think of a mastectomy, but that's not always the case, right?
Correct. So I was mentioning earlier, some women are great candidates for what we call breast conservation. And breast conservation simply means that instead of undergoing a complete mastectomy, patients can undergo a partial mastectomy, which can help preserve breast tissue, likely the nipple areolar complex, and the sensation and the sexual function that carries with it, as Dr. Lindau was mentioning. So we can offer reconstructive techniques after partial mastectomy, which we call oncoplastic reconstruction, in order to use the remaining breast tissue or bring in tissue from somewhere else to restore breast form and sometimes even improve the cosmesis of the breast with cancer and the other breast to make it more symmetrical. Now, for women who do have to undergo mastectomy based on the characteristics of their tumor, the aggressiveness, the type of their cancer, then we do have options for reconstructing the entire breast. These typically are broken down into two categories: alloplastic or implant-based reconstruction, and autologous or using your own tissue types of reconstruction. And there are many places in the body where we can take tissue from to actually reconstruct the breast with a patient's own natural skin, fat, and soft tissue that can lead to, again, a very, very natural breast. And there are some benefits of using that type of reconstruction.
Now, I want to remind our viewers that we will take questions live during the program. Just type them in the comment section. We'll try to get to as many as possible over the next half hour. And Dr. Garza, can you expound on that a little bit, because that's intriguing to me when you think about using the person's own tissue. I would imagine there are a lot of advantages to doing that.
Well, I think that breast reconstruction is really personalized. So we can't say one type of reconstruction is definitely better than another. It's really based on the patient's body habitus, their goals, again, the type of cancer that they have. But specifically talking about autologous reconstruction using one's own tissue, you're right, there are some benefits in avoiding using synthetic materials in the breasts. In addition, we can use a patient's own skin and fat, and we can also take some of the sensory nerves from, say, their abdominal, thigh, buttock tissue, with the abdomen being the most common area where we borrow tissue from. And we can actually reconnect the nerves from the low abdomen to nerves in the chest that normally give sensation to the breast in order to try to reconstruct and preserve sensation in the breast, which, as Dr. Lindau mentioned, is important for a patient's sexual and psychosocial well-being.
So, Dr. Lindau, when we talk about restoring breast function, what exactly does that mean? I mean, I think we know the basic functions of the female breast, but specifically, can you tell us kind of what you're getting into there?
Yes, it's fascinating to look at the physiology textbooks. The description of what the female breast does is oftentimes limited to lactation or making milk to feed a newborn. Well, of course, the breasts have many more functions than that. And over the last couple of years, we've been talking with women systematically to understand their perceptions about all the things breasts do. As we've been discussing, breasts play an important role in sexual function, as Dr. Garza alluded. Breasts also play an important role in psychosocial function. For example, women talk about the importance of their breasts just to feel the positive pressure of a loving hug. The temperature of the breasts is important to women. So breasts both help to thermal regulate the chest wall. Without breast tissue, women can feel very cold. It can be a chill that's hard to address. And they also feel that the temperature of their breasts to their partner, to others, is important in terms of how they feel intimately. For example, having a breast that feels cold to your partner's touch can be a distressing feeling for a woman. Women describe the breast mobility, like breasts bounce up and down, breasts move when a woman moves through the world or exercises, and nobody really thinks much about their mobility until it's reduced or gone. So there are a whole variety of functions, social, emotional, sexual, psychological, that the breast performs. And in our ideal world, one day we would restore not only sensation to the breast, but the whole range of breast functions when we go about restoring breast form for women after breast cancer treatment.
Yeah, it's really interesting, and I never even thought of the temperature aspect, and that's a fantastic point, because you would feel a temperature difference. And can we talk a little bit about sensation, since you just mentioned it a moment ago, because I do know oftentimes when you do have a surgical procedure, nerves get cut and that sort of thing, and sometimes it takes a long time for them to come back.
Yeah. You know, it's on the one hand, we'd love to be able to preserve and restore pleasurable sensation, what science calls hedonic sensation for women, and that ought to be our goal. But the lack of any sensation at all for a woman in her reconstructed breast causes a problem called disembodiment, or the feeling that their body is not necessarily theirs. And in the sexual context, what we're learning is that this can be quite distressing, because a beautifully reconstructed breast that looks great to the partner might be a perfectly appealing and attractive and of interest to the partner. But you can imagine for a woman, it can be an uncomfortable and sometimes really distressing feeling to have another person be quite interested in or even aroused by a body part that she herself feels disconnected from, or she can't even feel. So if we could restore even that pressure sensation, or a woman's awareness that an intimate part of her body is being touched, we think that would be some progress, absolutely.
Yeah. We want to remind our viewers that we will take questions during the program, so type them in the comment section and we'll get to them and give them to our experts here. And we do have one from a viewer, and this is from Kathy. She asked, Dr. Garza, where on the body do you take other tissue to put in the breast?
So if we are talking about reconstructing the entire breast using your own tissue, some of the most common areas are the back, kind of the mid-back under the bra roll. There is some tissue there that we use as part of a latissimus dorsi flap. We use abdominal tissue, I would say, most commonly. Also, inner thigh, posterior thigh, and upper buttock tissue is commonly used for that autologous type of reconstruction.
And does that just vary from patient to patient?
Yes, it varies from patient to patient in terms of what tissue they have available, the volume of tissue they have available, and that, of course, is measured with the size of breast, the type of breast that they'd like to have.
So you've talked a little bit about some of the various options and techniques. Are there any other options and techniques, Dr. Garza, that we may not know about?
Well, I think one of the advances in the past several years in breast reconstruction is preservation of the nipple areolar complex. And although patients may not have complete sensory recovery after mastectomy, we do know that some sensation does return through the skin. It can take several months or even years for sensation to come back. But preserving the nipple areolar complex, whether it is with implant-based reconstruction or using your own tissue, does carry a benefit to the patient in terms of the way that they feel about their breast, the way that they feel about their body. And that has been shown in our clinical research within plastic surgery, that nipple preservation carries a psychosocial benefit and a benefit to a woman in how she views herself. Now, if for some reason, from a cancer standpoint, the nipple areolar complex cannot be spared, we have good news, because even doing reconstruction of the nipple secondarily, using your own skin or even nipple areolar complex tattooing, carries a similar benefit to a patient. So the more we can restore the outward appearance of the breast, we do know that that does lend itself to an improved sense of self in terms of self-esteem, psychosocial well-being, and sexual well-being. And now we're trying to improve on that even further and introducing sensory recovery to the breast as well.
Interesting. Now the question from a viewer, can someone consider reconstruction perhaps a few years post-mastectomy?
Yes. Reconstruction can be done either in an immediate fashion at the time of a mastectomy, or it can be done in a delayed fashion. And that could be months or even years after a mastectomy. Many of my patients come having lived without a breast for several years and have decided that they would like to have a reconstructed breast, that they don't have to put on a prosthesis in the morning to go about their day and feel whole. And so implants and your own tissue can be used to reconstruct your breast even years after mastectomy.
So, Dr. Lindau, this is a question I've been dying to ask you as I've seen it on the list, and that is about the Bionic Breast Project. Is there a way for women to get involved? And what exactly is involved in the Bionic Breast Project?
So the Bionic Breast Project is a program of research supported by the National Cancer Institute that combines the expertise of my lab, clinical and human researchers, with that of the University of Chicago laboratory of Dr. Sliman Ben-Smeya. Dr. Ben-Smeya, Professor Ben-Smeya, is focused on restoration of touch to prosthetic hands. And in response to repeated quests for help from my patients who are looking for a solution to the problem of numb breasts after mastectomy, I reached out to him to say, you know, if you're able to restore sensory function to prosthetic limbs, can you imagine this being possible to restore sensory function to the reconstructed breast? Now, Dr. Garza is describing techniques that preserve nerves. And as she mentioned, there are some patients, many patients, who have procedures where the nerves cannot be preserved. So the Bionic Breast Project has been looking at using biocompatible or biosensor technology that's been used in other bionics contexts to see if we can preserve or recover sensory function in the breast. The program of research has involved, as I mentioned before, talking with women about what their breasts do, how their breasts work, so we can really have a fuller understanding than just lactation as the function of the female breast. And also studying using psychophysical testing, excuse me, exactly how the breasts work, how they perceive various kinds of sensation in the regular state, I'm sorry, and in the aroused state. I'm going to take a sip of tea.
Yeah, go ahead and take a sip, and then we'll come back to you here in a minute, because I'm interested in this, and we've put up the little graphic at the bottom of the screen that has info womanlab.org. Do you want people to contact you there and reach out? Is that how you're going to get more information and hear some of these stories from women?
You know, wherever we've had the opportunity to talk about the Bionic Breast Project, whether it's been with my colleagues at the University of Chicago or out in the real world, we have women raise their hand to say, wow, that's really interesting, or I have something to say about that, and can I get involved? So Woman Lab, WOMANLAB.org, is a University of Chicago website that we use to share everything we know about preservation and recovery of sex in the context of cancer and other illnesses. The email info@womanlab.org is a way people who are interested in Bionic Breast Project can connect with us, and we can share out as we have new opportunities to become involved.
And see, Dr. Lindau, this is one of the areas where I think UChicago really shines because we are a research institute. We have the campus here, we have University of Chicago with their labs, and obviously there's a lot of work that goes on back and forth between both the medical facility and the labs. And again, I just think this shows the value of that. I don't know if you want to talk about that a little bit, but certainly it's I think, an advantage.
Absolutely. And I want to add one more ingredient to your observation, which is the tremendous community we serve. So it's in all of the work that I do, we have patients involved as advisors and advocates. So they're at the table with the scientific teams directing us on the questions that are most important, the problems they want to see solved, and helping to make sure that as we do our scientific work, that we're doing it true to what the real needs are on the ground. Over my 20 years at the University of Chicago, I've benefited immensely from the proximity of our medical center to our university campus, with our fantastic, brilliant college students who come from all over the world to study with us, and to our generous and highly competent community members who want to be part of solutions to big problems.
That's a fantastic point. We really are part of a community and a neighborhood here in Hyde Park, and it's a very important part of who we are and what we do. Dr. Garza, can you talk to us a little bit about the risks of breast reconstruction? Because I imagine that's something that women think about quite a bit if they're going through a situation like this and they want to weigh what they decide to do.
Sure. Well, everything that we do in terms of reconstruction obviously is surgical, so it adds some surgical complexity to the management of breast cancer. Some women are a little bit afraid to undergo additional procedures in addition to already complicated procedures to remove part of their breast tissue, their entire breast, and lymph nodes. And so there are some risks associated with breast reconstruction, but by and large, it's a very safe operation. It's not terribly stressful to the body to do breast reconstruction. With implant-based reconstruction, probably the number one thing that we worry about is infection, because we are using, again, a prosthetic material to reconstruct the breast. So infection can happen. There can be problems with wound healing that can happen with implants. Using your own tissue is a more complicated procedure from a technical standpoint. It's something that we do excel in here at the University of Chicago. We do these types of surgeries multiple times every week, but they involve most of the time detaching tissue from the one part of the body and reattaching it to another part. And this tissue is like a transplant. It's living tissue that's vascularized, meaning we have to reconnect arteries, veins, and sometimes nerves to keep the tissue alive. With that comes the risk, of course, that some or all of the tissue could not survive for one reason or another. So it is technically difficult, and the procedures can be somewhat stressful to the body. But women tend to do very, very well with these types of reconstructive surgeries. And I think the most important thing is understanding upfront what the type of reconstruction a patient wants, what it involves, that they understand the impact that it can have on their work life, on their family life, on their physical well-being long term.
So, Dr. Garza, in the very first part of the show, you mentioned lymphedema, and you talked just a little bit about that. Can you kind of describe to us what exactly lymphedema is, and is that a big concern for women?
Yeah, so lymphedema is swelling of a body part. Typically, we see it with the upper or lower extremity. And in breast cancer patients, lymphedema is considered secondary lymphedema. It usually affects the arm after lymph nodes are removed under the arm as part of breast cancer treatment or as part of the radiation that may ensue. And Here at the University of Chicago, we are a center of excellence for lymphatic treatment, and we have several research studies that are ongoing. And I think some of the most exciting areas of my work and that of my colleagues is focused on, or are focused on, lymphatic surgery. So we have the ability to offer procedures at the time of mastectomy to decrease the risk of developing lymphedema in the first place. Lymphedema is a chronic disease. It is not typically considered curable. So prevention holds a lot of promise for patients, particularly breast cancer patients. But for patients who already have lymphedema from previous surgical treatment, radiation treatment, we also have surgical procedures that can be offered to help improve their symptoms and improve their quality of life, decrease the edema that they have in their extremity. Those are in the form of lymphovenous bypass types of surgeries or lymph node transplant types of surgeries. And those procedures can sometimes be done in conjunction with a breast reconstruction.
Dr. Lindau, we've got about 2 minutes left. Can you talk to us one final pitch for the Bionic Breast Project, and what do you hope for from women? I noticed we did have the I guess it's an email address. Do you want people to email you, or do you just want them to go to the site? What do you hope for here?
Well, it would be fantastic if people want to know more about how they can contribute to the Bionic Breast Project or learn more. info@womanlab.org. And what I want is to work alongside Dr. Garza, providing the fullest range of options to help restore breast function in women who do get great care in terms of restoring breast form.
Well, that is perfect. We are out of time. You two were fantastic, shared a lot of great information with our audience, so we certainly appreciate that. And thank you to our viewers for your great questions. Remember to check out our Facebook page for our schedule of programs coming up in the future. Also, if you want more information about UChicago Medicine, take a look at our website at UChicagoMedicine.org. If you need an appointment, you can give us a call at 888-824-0200. And remember, you can schedule your video visit by going to the website. Thanks again for being with us today, and I hope everyone has a great week.